So here's your risk factors for pre-diabetes and diabetes. So increased risk with a first-degree relative with diabetes, definitely looking at that central obesity and the BMI greater than 25 or any 20% over ideal body weight. We know that all ethnicities, besides Caucasian, have a higher rate of diabetes mellitus than Caucasian. But we know that even with the white population, there is a huge number of patients with diabetes. So statistically, it's just high all around. Increased with age, greater than 45 years. Gestational diabetes or a large weight baby. There's a 30 to 40% chance that mom will develop diabetes, especially if they're obese or do not lose some of that pregnancy weight that increases. Of course, increased total cholesterol is a significant risk factor for not only coronary artery disease, but also the development of prediabetes. So a low HDL, remember that's our good cholesterol that is impacted by exercise, or a high LDL, our low density lipoprotein, which is our bad cholesterol, which is mostly dietary indiscretion. So again, looking at lots of different things besides just blood sugar. I love this slide, and I know it copies in a little blurry, but take a look at where the 0 is. This is the years, 0 is from when they would be getting diagnosed with diabetes. So you can see that it's an average of 7 to 10 years that somebody has pre-diabetes before they're actually diagnosed. And then take a look at the pink and the orange bar. When we're developing or starting to develop the macrovascular and microvascular complications that we're going to be talking about. So we're developing complications before a person even knows that they have diabetes or have pre-diabetes. So again, just really validates how important it is to get that diagnosed sooner than later. What I also really love about this is you can see that purple line that's showing you that initially there's going to be an increase in insulin production. And then you can see where it falls off, or I guess it's the yellow line there, where initially it's meeting the needs of the increased insulin amounts that's needed, which is the insulin resistance. And then the yellow line, the insulin secretion, you can see where it's already starts declining the amount of insulin that's being produced. By the time we're diagnosed, that amount of insulin that's being secreted by the pancreas is already on the downfall. So this is just a really big problem that it just shows you that insulin resistance problem, but also shows you how we're developing those complications already. So this is just a quick comparison slide of type 1 and type 2 diabetes. You have a textbook. In your textbook, there's a table side by side showing you type 1 and type 2 also. That's a really great way to learn this, to kind of look at the similarities and the differences. You see the difference in incident, much more common with type 2, 90 to 95%. You see the time frame, typically under the age of 30 for type 1 and over the age of 30 for type 2. We see that type 1 is a loss of beta cell function, whereas type 2 is insulin resistance. Yes, there is going to be progressive decline in beta cell function as well, but the main starting point is the insulin resistance, the need for more insulin, and that's why the beta cells get tired. So, and then with type 1, the DKA. So signs and symptoms of DKA are often first. And then the bottom right picture, the acanthosis nigricans. This is where we see primarily in dark-skinned individuals, but you'll see kind of that dark, velvety discoloration, almost like a band around the neck. We can see it on the back of the neck, armpits, groin. So we see it more commonly and can do some screening with children in schools. We do this at Niashing at the Mille Lacs Reservation when we do hearing and vision. And that band of darkness is basically called acanthosis nigricans, but it basically is showing the onset of insulin resistance. It's not diagnosing type 2 diabetes, but it's basically saying that they have insulin resistance already. Here is a second compare and contrast slide between type 1 and type 2. You can see type 1 is a shorter duration of symptoms. Ketoacidosis is the normal initial presentation and the absolute need for insulin for survival. Type 2 is going to be a longer duration of symptoms. Remember, they're going to have that prediabetes and insulin resistance kind of starting to compile. They will have glucose in the urine without ketoacidosis. They will not have fat breakdown in ketone bodies, so they will not present with ketoacidosis like type 1 diabetics do. They typically have more of the hypertension, high cholesterol, obesity. First treatment is going to be diet and exercise, and then they can definitely move into oral hypoglycemics. And again, if they develop enough insulin or resistance over time, they may require insulin at some point. What you can notice here between type 1 and type 2 diabetes, I purposely have all of the same signs and symptoms kind of at the top. So you can see with anybody that has hyperglycemia, we have the 3 Ps, polyuria, polyphagia, polydipsia. Anybody with hyperglycemia is going to be at risk for more infections, delayed wound healing, all of that. And fatigue pretty much can go with either one as well. The differences kind of come more towards the bottom. So in type 1 diabetes, we will see more of the signs and symptoms of diabetic ketoacidosis. They can have the unexplained weight loss and nausea and vomiting and abdominal pain. They'll get that as a result of the acidosis and that compensatory mechanism of vomiting to try to get rid of some of that acid. So type 1 has those different things, kind of, especially if they are having a complication of type 1 diabetes, such as diabetic ketoacidosis. Type 2 diabetes then definitely looking more at more long-range problems, such as change in vision, again, poor wound healing, any of that neuropathy or numbness or tingling in the feet. Again, just to reiterate on the chance or frequency of infection, remember back to immune and when we talked about if your blood sugar is consistently greater than 200, that is the threshold in which basically all of it freezes and disables the white blood cells from fighting infection. That's one reason why there's increased chance of infection. Another reason is bacteria basically feed on sugar, so bacteria love sugar. So if we have a higher sugar, there's more chance of bacteria in getting an infection. And then the other piece is just the decreased circulation, poor blood supply, decreased blood, nutrients, and oxygen getting to the tissues, which will result in delayed wound healing and more chance of infection. I like this visual on top 7 symptoms of adolescent onset diabetes. We don't really call it that anymore. I mean, it's type 1 and type 2, but we know that type 1 is more likely to develop in less than 30 years of age and more commonly in kind of the early teens and teen years. So you can see the diabetic ketoacidosis is the main presenting symptom. You see the polyuria, polyphagia, polydipsia, and then the weight loss and fatigue and things that could go along with that ketoacidosis. Another creative memory notebook on type 1 diabetes, so if you like these, they can be very helpful. And the creative memory notebook for type 2 diabetes. So just a little bit on gestational diabetes. The incidence is approximately 2 to 5%. It can be type 2 diabetes that is kind of unmasked early, so it can be a precursor 30 to 40% of the time that patient would develop type 2 diabetes. We also know that there's big hormonal changes of pregnancy that demand more insulin than the body can make, which is why we're ending up with the gestational diabetes. Increased levels of estrogen and placental hormone basically also can inhibit the action of insulin producing action of insulin, which produces the insulin resistance. So there's changes of insulin production, there's changes of insulin resistance, and this is why a mom can end up with hyperglycemia during pregnancy. Another big thing to keep in mind is that after the baby is born, the baby is at risk for low blood sugar. So remember, the fetus has adjusted to the mom, so making more insulin. So once the baby is not in utero anymore, it is not able just to shut it off like a faucet handle, it's still going to be overproducing, and so that's why the baby could be hypoglycemic. So this is a very high priority assessment in any baby that is born to a mom with diabetes or a mom with gestational diabetes. Couple bullet points on breastfeeding. We know that breastfeeding has a very good anti-diabetogenic effect, so lowers blood sugar. We know that there is going to be more energy demands and a decreased amount of insulin need in breastfeeding moms. So this is a good time for you to kind of stop off and just write on your sheet of paper the differences between type 1 and type 2, and just ensure that you're getting the gist of the differences, because there are very clearly defined differences. Yes, there are some similarities too, but we want to be able to definitely help our patients differentiate between the two and educate appropriately. So the correct answers here for risk factors for type 2 diabetes: obesity is yes, Native American yes, family history of type 1 diabetes or any first degree relative with diabetes yes, personal history of polycystic ovary syndrome yes. So A, B, C, and D is the correct answer. A random serum glucose of 136 is not indicative of the type 2 diabetes. So correct answer here is D. Remember that fasting blood glucose of 126 or higher on at least 2 occasions will diagnose diabetes. We will now get into discussing the goals of treatment for diabetes, and really the ideal is just healthy living, feel better, maintain your health, eat well, prevent acute and long-term complications. So we're going to kind of go through many different bullet point areas, but the ideal is just to normalize the insulin activity and the blood glucose levels to help to reduce the development of those vascular and other complications. So we have an ABC's acronym for diabetes, and this really helps us to remember that there are other things besides the actual blood glucose that we're concerned about. So the ABCs, when it comes to prevention of complications for diabetes, the A stands for the A1C, the glycosylated hemoglobin, the B stands for blood pressure, and the C stands for cholesterol. So these are all very important things that we want to manage and keep at a normal level. So again, it is not just that blood sugar reading alone that's helping us to prevent these complications. So the A1C is your blood glucose over time, and it measures basically, it can be measured quarterly because it's measuring basically 120 days or a 3-month period of what your blood sugar has been running over that time. We'll be talking about that here more in just a minute. So minimum of a couple times per year, but quarterly is ideal. Less than 7% is what we want for a glycosylated hemoglobin, and the lower the better. Blood pressure, again, less than 120/80, but we just want to make sure that that blood pressure is managed, that we're taking antihypertensive medications if needed, that we're exercising, losing weight, and that can also help positively affect blood pressure and cholesterol. And then cholesterol, of course, checking at least a minimum of 1 time a year. Weight reduction is huge. Weight loss, decreased saturated fats, decreased cholesterol, exercise, all of those things, if somebody has pre-diabetes, can basically prevent the onset and development of diabetes. So it is possible, if you find out in that pre-diabetes period, to make your adjustments and modification to prevent yourself from having diabetes. So as I stated, the hemoglobin A1C, we kind of shorten just for A1C, but also is called the glycosylated hemoglobin. But when we check a patient's A1C, we tell them we're looking at, the past 2 to 3 months of your blood sugar. And what we're looking at is they're looking at the red blood cells. They have a lifespan of 120 days. So how many percent of hemoglobin molecules have sugar attached. So you can see this picture. I sometimes keep it simple for patients and just say how many sugar-coated donuts versus, just the regular donuts do we have. And sometimes they can make understanding of that. You will see that the normal is 4.2 4 to 5.6, so that's the normal, and so we want to have 7% or less would be really good diabetes management. They might run somebody's A1C a little bit higher if they're frail or elderly, because we don't want to run them too low on their blood sugar if they can't recognize hypoglycemia or have any complications related to that. But ordinarily you want it less than 7. This picture would be a really excellent diagram for patients as well, where they can see, that the red blood cell lives for approximately 120 days. Hemoglobin is contained in the red blood cell, and glucose sugar enters in the bloodstream and the red blood cell. So it kind of shows what normally is going to happen, and then it shows how glucose naturally binds to the hemoglobin molecule, and this binding creates the glycated hemoglobin, or the hemoglobin A1C. We talk to our patients about their A1C and what that means as far as long-term glucose control. So I really like this picture just to kind of show you, if they're 6% for the A1C, they have been running an average sugar of 126, which is really good. Again, this is not a fasting blood sugar. This is their average blood sugar for even when their meals are spiking and when they're not. So you have to keep that in mind and make sure patients don't think it's a fasting that you're talking about. 7% average in 154. Now you can kind of see as it goes up, you have somebody that's running an A1C of 10%. Their average blood sugar is 240. So that's really, really high. And so this sometimes can help patients to visually see why this A1C is so important. The third bullet on the left hand is also super important, because I always like to tell patients to help them motivate, to give them some reasons and some statistical proven facts about what is or what isn't. So for each 1% over 7 for their A1C, it is estimated to be a 30% greater risk of long-term complications such as neuropathy, retinopathy, stroke, peripheral vascular disease, heart attack, etc. So for every 1% they're higher than 7, there's a 30% increase in their, complications. So I like to use it the opposite and say, hey, good job. You decreased your A1C from 9 to 8%, and this is how much you have decreased your chance of complications, for example. It can be very effective and very motivating to the right person. This chart can also be a good one used for teaching purposes with the A1C and the average or estimated blood glucose range. So you can see at 6% for the A1C, their blood sugar is ranging from 126 to 151. And again, that's an average range, not too bad. And again, the higher it gets, the worse it gets. So, I just recently took care of a patient that had an A1C of 12 something. I hadn't had that high of a one in a long, long time. So their blood sugars are averaging 298 to 324. That is extremely, extremely high. And if you think of that 30% increase in complications for every 1% over 7, and you're at 12 or 13, that is a huge increased probability of complications. Targets for blood pressure are pretty self-explanatory. Don't have a lot to say here. More than 65% of all deaths in persons with diabetes are caused by cardiovascular or thrombolytic events. So blood pressure management, cholesterol management is so, so important. So again, more than 65% of all deaths in persons with diabetes are cardiovascular related. The other thing is just some general teaching on key steps to lower blood pressure. So certainly take your blood pressure meds as prescribed, but even just reducing salt, losing weight, quitting smoking, decreasing alcohol, eating more fruits and vegetables. Again, you want to think big picture. What are all of the things that I can talk to my patients about that are going to help lower their blood pressure? So again, losing weight, exercising, reducing alcohol, quitting smoking, reducing salt, eating more fruits and vegetables, and taking their blood pressure meds are things that can be very helpful. Targets for lipids. Again, this is just a nice review from cardiovascular where we had talked about our LDL or our bad cholesterol, kind of where we want those numbers. Our good cholesterol, we typically for sure want greater than 40. You can see by gender this separation, but greater than 40 is a good hard number to for sure remember. And then triglycerides. So they're going to measure all of it. They're going to measure your total cholesterol. And again, I encourage you to think, what are steps that we can tell our patients to lower their cholesterol and lower their lipids? So eat less saturated fats, right? Make sure we're having more foods high in fiber, again, the fruits, the vegetables. Make sure we're taking our cholesterol-lowering agents, such as all of our statins. Remember, atorvastatin, those all end in statin. Those are our cholesterol-lowering agents. What else do you know about statins? Well, no grapefruit juice with those, just like that, and calcium channel blockers, and then checking liver function tests. Those are some additional things that we talked to them about their medication teaching. Exercise, of course, is going to help raise that HDL. Dietary is going to help to lower the LDL part of things. We talked a little bit about cholesterol and eggs. Basically, dietitians will say, 4 egg yolks per week is acceptable. All the egg whites you want is fine, because eggs are a healthy protein source and they're not the bad guy, but obviously we have to be a little bit mindful of not overdoing it as far as cholesterol management. So here's just a summary slide for the glycemic control. I would just focus mostly on the first 2 columns, the A1C and the fasting blood glucose. We have slightly different parameters, the International Diabetes Center versus the American Academy of Endocrinologists. So again, not that you have to memorize which one is which, but you can kind of see those numbers where they are sitting at. So diabetes management is definitely a very holistic approach, and there are basically 5 key components: our nutrition and dietary education, our exercise information that we provide, blood glucose monitoring. Do they know how to do that? Do they know what they're expecting? Do they have the working equipment? Of course, all of the pharmacological and medication teaching, and then just overall education that doesn't necessarily fall into any one given category. So nutrition, diet, weight control, blood pressure management, medications, all of those things are going to become very important in our diabetic teaching plan. So myplate.gov, if you haven't looked this up recently, this is basically the picture of how they're defining what is the recommendation for good healthy eating, and you can see half of your plate is fruits and vegetables, and for a diabetic patient, larger portion of vegetables, just because there is a fair amount of sugar and carbohydrates in fruit. Carbohydrates are basically sugars and starches. That's a good starting point to think about what does contain a carbohydrate versus protein, etc. So we'll be getting more into carb counting here, but this is we don't want to overwhelm people initially. We very much start small. We start talking about just general small changes in eating healthy, and then can get into more of the nitty-gritty of the carb counting, etc. I like this picture also because you can see how you can really eat well. We can eat really good if we add more of the right foods. We can get plenty to look like we're still getting a lot. I mean, there's a lot of food on this plate, and it's very healthy. So again, do we have a quarter of lean protein? Do we have half that's non-starchy vegetables, a real small portion of some fresh fruit, which kind of gives us a little bit of our sweet and sugar craving, and again, a smaller amount of the starchy vegetables or whole grains or rice or potatoes that are going to be high concentration of carbohydrate. So there really is no such thing as a diabetic diet. It's really just healthy eating. It's really what all of us should do as far as portion control, more vegetables, less carbs, less starchy stuff. So we'll start by talking to them about carb counting. We'll have to understand both the grams and the carb choice, because some people are still going to be doing carb choices, and some people are going to specifically be very precise on grams of their meals. And most facilities are going to counting by grams now, but not all patients are capable of doing it by grams. So there's still going to be both both that you do need to know. So 15 grams equals 1 carb choice. A typical meal will be 3 to 5 carb choices, or for younger children, 2 to 4 per carb or per meal of the carb choices. So 15 grams total equals 1 carb choice. Less than 5 grams if we're doing carb choices is considered free. So we're going to be doing a bunch of practicing on carbohydrate counting. We're going to do more by carb choices. However, we know then that you can apply it to the 15 gram rule. Clinically, you're going to be doing it by grams. I'm not sure what's going to show up on NCLEX, if it's going to be grams or carb choices. I do have to believe that if they are having you do it by grams, they're going to have to give you a menu telling you how many grams are contained in each food product, and then you would have to figure out the percentage of what they ate to calculate that, because that isn't something that we could just memorize, like how many grams are in, a certain serving size of something without looking and reading a label. So they're going to have something for you to do that. It is realistic for us to know lots of different food items that are approximately 1 carb choice or approximately 15 grams. That you should know, and that you do need to study and make sure you have that down. I have a slide coming up with a good summary of most common food items that equal 1 carb choice or 15 grams. So that's something to look for when you're starting to study.